Sure. Thank you. I was roped into this one, so I feel like it's a little bit of a rhetorical question these days, but we'll go through some of the data and talk about a case here. So, asymptomatic aortic stenosis, watchful waiting, or early action. So we're just going to talk a little bit about the natural history, identify some of the risk factors, and then do a little brief review of some of the recent data. So we'll start with a case. Mr. H, this is one of my patients. He's a 72-year-old man with hypertension, progressive aortic stenosis. He has an echo with some mild left ventricular hypertrophy, but a preserved ejection fraction. He has a trileaflet valve with severe stenosis, aortic valve area of 0.9 centimeters squared, and mean gradient of 42. He jogs daily, no chest pain, no dizziness, no syncope, really, pretty classically asymptomatic. So what are our next steps? We do conservative measures, watchful waiting, try to do some additional provocative testing, kind of, are you really a jogger? Are you a runner? How much can you do? Or do we go ahead and refer for aortic valve replacement? So just to review some of the natural history of aortic stenosis, we know there's a long latent or asymptomatic period, but then we have this kind of dogma that shows that there is some significant drop in survival once the patients are symptomatic. Classically, we talk about how once they have angina, it's about 5 years, syncope 3 years, and even less when they manifest heart failure. And we know that even in those patients who have no symptoms, there is about a 1 to 3% risk of an annual rate of even sudden death. So, asymptomatic maybe isn't necessarily all that benign. When we talk about defining asymptomatic, there's this subjective, the patient telling you that they're active, they don't have any symptoms, versus, some actual clinical objective testing. So, of course, in the guidelines, we can put them on a treadmill, look for some arrhythmias, some abnormal blood pressure response to exercise, or true symptoms. And then we look for some echocardiographic findings. So they have a little bit of decline in their LV function as manifested by a decrease in their global longitudinal strain or their fractional shortening. Do they have elevated biomarkers? Do they have pulmonary hypertension? What is their Agatston score if you did a calcium score or a CT on them? And we know in particular that these ones that have the little star by them have been associated with risk for higher, worse outcomes long term. So, so if we look at the guidelines, we know that when we're talking about asymptomatic patients specifically in the guidelines, they do recommend for class 1 in asymptomatic patients, those who have severe aortic stenosis and a drop in their LV function, as defined by an LVEF less than 50%. And also those patients who are having cardiac surgery for some other cause, if they're having bypass surgery, then of course you would do an AVR at the same time. Otherwise, they gave class 2 indications for patients who have very severe aortic stenosis as defined by a velocity greater than 5 meters per second, or in patients who have severe aortic stenosis with an elevation of their BNP, or those who have a significant increase in their aortic velocities over time. And then again, in patients who were seeing that steady decline in their LV function to less than 60%, but it hasn't yet met that criteria of less than 50%. So to talk about some of the other trials recently out in the last few years that support this intervention for early aortic valve replacement, there's this trial Recovery that was in the New England Journal. It basically looked at asymptomatic patients with very severe aortic stenosis, and they defined that as an aortic valve area of less than 0.75 centimeters squared with a velocity of greater than 4.5 meters per second, or a mean gradient of above 50 millimeters of mercury. And they showed it, and that was for surgical patients, that those had a significant decrease in their overall CV mortality versus conservative therapy. An additional important trial is the Avatar trial. This was published in Circulation. And they had patients with the more traditional severe aortic stenosis, met that regular criteria of an aortic valve area of less than 1 centimeter squared, with a velocity above 4 meters per second, a mean gradient equal to or greater than 40 millimeters of mercury. Those patients had to have a normal LV function and also normal exercise stress testing. And so patients who underwent surgical aortic valve replacement in that trial had a significant decrease in their composite of all-cause death, acute AMI, stroke, or unplanned hospitalization for heart failure versus conservative therapy. And then most notably, recently, this early TAVR trial was published in the New England Journal, and they took asymptomatic severe aortic stenosis, and those are patients still with the traditional aortic valve area less than 1, and preserved LV function, so just an ejection fraction above 50%. And they showed that early TAVR was superior to clinical surveillance, and that's to reduce the risk of death, stroke, or unplanned hospitalization for cardiovascular causes. So when we go back to Mr. H, he has hypertension, severe AS, preserved LV function, asymptomatic. What do we do next? What would you guys do?
But Bobby has the mic. Go ahead, answer that question, Bobby.
Yeah, so this is one of my panels here, but in general, we know it's not benign. There's some high-risk markers that help us, I think, to discuss with the patients when they're like, I'm fine, doc. I just ran a mile. I don't. And Bobby has a great case of a guy who was like convinced he was asymptomatic, but he was having syncope while he was running. And so somebody, trying to help your patient along when you need your aortic valve replaced. And I think too, there's more and more evidence that's supporting that us as physicians, we see this severe abnormality, and now we're having more evidence-based reason to intervene earlier, which is kind of what we've always felt we should do in the first place.
Yeah, so a couple things.